Thank you for the organisers for inviting me to contribute to this important scientific event. I'm sorry that I'm not there in person, but hopefully I'll be able to join you next year. My remit over the next 10 minutes is to discuss what do we mean by complex PCI. My name is Mamas Mamas. I'm Professor of Cardiology based at Keele University. So what is complex PCI? Well, this is a duck-billed platypus. We all know what it is. When you look at it, you know immediately this is a duck-billed platypus. But it's very difficult to describe. You know, how do you describe this? It looks like a duck, it's got fur, it's got legs. It's very difficult to describe. And the same thing with complex PCI. When we see a case, we know it's complex, but when we're asked, what do we mean by complex PCI, it can often be challenging to describe what we mean. And how have others gone to describe complex PCI? Well, this is the European Society Guidelines on Myocardial Revascularization, and they define complex PCI in terms of distribution of disease, i.e. the syntax score. And the syntax score considers coronary segment length, occlusions, whether it's a bifurcation, trifurcation, considers tortuosity of the disease, how long the lesions are, whether they're calcified or thrombotic, and whether the disease is in small vessels and diffuse. And when you consider all these factors, you have a score, and based on the score, you can be low, intermediate, or high syntax score. So that's one way of defining complexity and one scoring system that we use to decide whether a patient goes for surgery or PCI. Other scoring systems or other definitions of complex PCI have been developed. So this is the SCAI definition. And the SCAI definition considers anatomy, so in terms of multivessel PCI, calcified lesions, bifurcations, CTOs, vein grafts. It also considers equipment. So, if you need to do arthrectomy, that's a complex PCI. If you need mechanical circulatory support. And finally, and importantly, it also considers comorbidities such as diabetes, whether the patient's a surgical turn down, whether they have valvular heart disease, renal impairment, impaired LV function, and so forth. So you might start to see immediately that we've developed the concept further from purely anatomical distribution of disease to a multifactorial consideration around anatomy, around the type of equipment and the nature of the lesions, but importantly around patient comorbidities to define what complex PCI is. The European Society of Cardiology has also defined complex PCI by the lesion characteristics themselves. So if 3 or more vessels have been treated, or 3 or more stents have been implanted, or bifurcation with 2 stents, total stent length greater than 60 millimeters, CTO or left main, it's considered a complex PCI. And this is really where the concept of CHIP, complex, high risk and indicated patients, comes in. These are patients with complex PCI features. And this is, again, a transposition of patient comorbidities, such as surgical ineligibility, previous heart surgery, heart failure, diabetes, renal insufficiency, complex features in the coronary artery disease, such as multivessel, distal left main, complex lesions, such as bifurcations, calcification, CTO, and hemodynamic compromise. And when these 3 factors are together, then you have what is termed a complex, high risk and indicated patient for PCI. And when we've looked at this in the UK, the way that complex cases are defined in the UK, this is increasingly common. You can see that over time, the proportion of patients that become complex, high risk and indicated patients, so CHIP cases, from the stable angina perspective, have increased to about 1 in 3 of all cases undertaken in the UK. So complex PCI is becoming much more common. And this is partly driven by changes in the comorbidity of our patients as PCI techniques improve, as equipment improves, as patients become more elderly, they become more comorbid. And one of the measures of comorbidity is the Charlson Comorbidity Score that you see here, where you get points according to what condition you have, and you add the points up. And a score of 0 means that you're not comorbid. A score of greater than or equal to 3 means that you're severely comorbid. And you can see this data that we published from the United States in over 6 million patients, that 1 in 6 patients by 2014 is severely comorbid. The numbers now are closer to 1 in 5 patients. And so in contemporary practice, we're increasingly encountering multimorbid patients. And you can see that comorbidity index or burden, particularly in the severe patients, has an important impact on PCI outcomes. So with a death rate of 3%, bleeding complications of close to 9%. But there's other aspects of comorbidity. These are patients with cancer. This is an analysis that we published a year or two ago showing high complication rates in patients with cancer, particularly when you have metastases of close to 10%. Frailty, again, is another important consideration when talking about complex PCI. This is one of our publications where we analyse the outcome of several million patients, and you can see that in the most severely frail patients, the major bleeding rates in hospital are close to a quarter. In hospital death, 1 in 6 frail patients will die if they have a PCI, and stroke rates of about a third. So this is a very high risk cohort and would encompass complex PCI. One of the things that we often think about is that we often treat complex PCI as a single entity, but of course complex PCI represents many different patient characteristics, many different lesion characteristics. And it's unclear until recently whether different lesion characteristics in complex PCI have different outcomes, and whether the outcomes are driven by the number of complex features. And this is something that we studied using the Ultimaster registry, which is a large registry of over 35,000 patients with 1 year follow-up. And the primary endpoint was target lesion failure, which was a composite of cardiac death, target vessel-related myocardial infarction, and clinically driven target lesion revascularization. We published this in Your Intervention, and we defined complex PCI as per European Society of Cardiology guidelines that I covered earlier. And you can see that, again, in this study, about a third of the population had complex PCI features. A fifth of these had 1 to 2 complex features, whereas 3 to 6 features, 7%. The most common complex feature was multi-vessel treatments, which was in 16% of patients, and CTOs accounted for 5% of patients. And you can see, as expected, that outcomes are worse in complex PCI, both in terms of ischemic outcomes as well as bleeding outcomes, interestingly. We also see that the outcomes for individual complex lesions vary. You can see that actually the worst outcomes are for bifurcations with 2 stents, whereas for CTOs, certainly in this registry, there doesn't seem to be an excess risk of target lesion failure or cardiac death. Although for CTOs, we did see an increase in the risk of stent thrombosis. So really, this is telling us that for complex lesions, the outcomes of the PCI very much depend on the nature of the complex lesion. And this, finally, is looking at outcomes by the number of complex lesions. And you can see that target lesion failure, cardiac death, target vessel MI, or clinically driven target lesion revascularization all increase as the number of complex lesion features increase. So you can see the greatest or the worst outcomes are in those with 3 to 6 complex features, whereas those with 1 to 2 have intermediate outcomes, and the best outcomes are in those with non-complex features. So I think in summary, my take-home messages are these. Complex PCI can be defined in many ways. They mainly relate to procedural risk and the future risk of ischemic events. And you can characterize complex PCI by the distribution or extent of disease, i.e. syntax score, lesion characteristics that we've talked about, such as those defined by the ESC, patients' comorbidities, and I've shown you data around multimorbidity as defined by Charlson Index, frailty, I've shown you data around cancer, as well as patient hemodynamics. And the outcomes of complex PCI very much depend on both the type and number of complex features. So I'd like to thank you for joining me and hand over back to the panel.